So we're going to move on to the next bit now. Sorry, it's a little bit later than planned, but that was such an interesting topic. So we're going to talk about the exams. I know a lot of trainees are worried about exams and have lots of questions about exams, and that's the thing that I focus on most. So for those of you who don't know me, I am a portfolio GP now in full-time medical education. I'm lucky to be a fellow with the Royal College for GPs, and I've had lots of previous educational-based roles, both within general practice and outside of general practice as well. So I used to be a PD in the West Midlands. So I worked on a couple of GP training programs, and I used to appraise other GPs and be an examiner and be quite heavily involved in the GP recruitment process as well as having a strong interest in both AKT, advanced AKT training, and also international medical graduates as well. So I've done a lot of different things, but now we focus mainly on overall medical education. And apart from GP training, we help doctors both get through their exams, but also progress in their career. So whether it's from med school through to PLAB, through to getting into GP training itself, of course, and then post CCT. So I'll mention some of the things that we do going forward in this talk. So we're going to try and cover both exams then in a short period of time. I know it's quite hard to do that, but please do keep the questions coming in. I will try and stick around after and answer if I haven't gone through anything key during the talk itself. But just a quick reminder of the two big exams as we stand right now. So obviously your 3 years of GP training, ST1, ST2, ST3, your AKT exam window comes in from ST2 onwards, and your RCA exam window comes in from ST3 onwards. We heard in the morning from Martin Marshall from the RCGP that this is likely to stay the case now until at least middle next year is what Martin Marshall was saying, the chair of the RCGP. So RCA is here to stay at least for the short period of time. This will change. There's a new exam being created as we speak. So we should be hearing something about that going forward in the near future. So what are the two exams? And of course, AKT, Applied Knowledge Test, and RCA, which stands for the Recorded Consultation Assessment, both very, very passable. A lot of people contact me with, even from ST1 onwards saying, gosh, I've heard lots of difficult stories about these exams and people taking it 3, 4, sometimes 5 times. But they're both very passable. But like with any assessment that you've done up to this point and anyone that you'll do in the future, you need to be smart about it. You need to understand a little bit about what's being assessed from me. It's one thing to put in thousands and thousands of hours, but if you're not hitting the right things in terms of understanding where my time is best spent, then the number of hours doesn't equate always to a pass. But they are very passable, and we're going to hopefully touch on a few things today to get you on that road to smart preparation, rather than kind of giving up months and months and months just to put in the time. So just before we get started, just again to get an idea of where we are in terms of people on board, let's just see how many of you guys have taken the AKT. So just click a yes or click a no. So about 3/4 of you haven't taken AKT yet, and about 1/4 of you have. So if you have, then this will all be old news for you, but apologies. So the first thing about AKT is it's applied knowledge. So it's different to any assessment you've done before. A lot of assessments you've done in the past relied on you learning certain bits of knowledge. So do you know enough to be at the stage of your training? Now, by the time it gets to AKT, it's kind of assumed that you know a lot of knowledge by now. And now it's the application of that that is always being tested. So when you're sitting in your room as a GP, when someone presents with something, yes, you're expected to know, for example, the commonest causes of left-sided heart failure, but it's kind of assumed that you know that bit. It's now, what are you going to do right here, right now in this situation? And you've got 57 seconds, which is what it is for each question, to make this gut feeling decision. And that's a very different assessment to what perhaps in the past you would have been trying to prepare for. So learning lots and lots is not going to always necessarily increase that score. It's the application, the problem solving that is really important for the AKT. And that's sometimes very overlooked in preparation. We talk a lot about technique and how to almost think a slightly different way. And that's where the applied bit comes in. It's really important to understand from the start. 200 question exam, 3 hours, 10 minutes, so approximately 57 seconds per question. Some people do get slightly longer, but most people will get your 3 hours and 10 minutes. And the breakdown in terms of questions is the majority being clinical, so 80% of your questions will be clinical in nature, and we'll do examples of these in a second. 10% are stats and evidence-based, and 10% is kind of admin, organizational, managerial type things. And we'll cover these in a bit more detail in a second. And lots of different question types as well. I think it's just changed microphone. So yeah, so the majority are going to be single best answers. So you get 5 options and you have to choose the most accurate. And I say most accurate because it's not always the fact there's only one right answer. There may be 2, and it's about which is the most appropriate correct answer. So we'll talk about that in a second. EMQs, where you have up to 15 sometimes different answers, and the same set of answers relate to 3 different questions. There's a slightly different technique that you'll be looking at from an EMQ point of view, and there are a few others as well that you may need to do a little bit of typing, for example, but the majority are SPA and EMQ. It's around £450, changes from time to time, and we did have a bit of discussion with Professor Marshall earlier on in the day about pricing around these exams, and you take it at various different centres across the UK, so it's not any kind of centralised exam. When should you take it? I often get this question. You're eligible, of course, from ST2 onwards. So some people choose to take it the moment they can. So for example, if you're on August to August full-time normal rotation, then the first opportunity would be the October of ST2. And lots of people start preparing with having that as their plan in mind, whereas a lot of trainees still do AKT in ST3, and that's something that can be done. It's perfectly fine to do that, and you have to weigh up the balance, I guess, of trying to do 2 assessments in the final year, whereas the traditional approach from what I've seen is that people try and get it done in ST2, but you don't have to. 3 opportunities to do it in the year: January, May and October, so you can choose it depending on things like rotations and how busy you're going to be and when you feel ready. Maximum of 4 attempts. Can be a 5th in certain circumstances, but generally you want to try and get it done within 1 or 2. It's worth considering what rotations you will be in. It takes a lot of time and effort and energy out of you in terms of preparation for AKT. So if you're doing a busy A&E rotation, for example, or a busy acute med rotation, some people tend to not want to do AKT then just because of the time it takes out of you. Whereas other rotations, traditionally people say things like general practice, of course, and also psychiatry are typical ones that people think, okay, I could try and put a bit of time away for AKT, because it does take a lot of energy out of you, like I said. Do I need to have done a GP rotation? Sometimes people say don't try and do AKT until you've done your GP 4 months or 6 months, depending on what you have. I've seen it both ways. A lot of people do benefit, of course, from doing a GP job because the AKT is getting you to think from a GP mindset, and that can be quite hard if you haven't done a GP rotation. But equally, I've seen people pass AKT without any problem having not done a GP rotation as well. So it depends a lot on how you feel about it, but you'll get a lot of different advice as to whether you should or shouldn't do AKT having done a GP rotation. Having talked about the fact that you can do it at any point, I've seen a lot of people struggle when it gets to ST3. ST3 is a very busy year. RCA obviously now is there. You've got all your final assessments. You've got all the stress of trying to get everything completed. So if you get an option and ST2 seems reasonable in terms of the rotations that you have and other things going on in your life, then it's good to do it in ST2. But some people do it in ST3, and if that works for you, then that is fine. We've mentioned the 3 sections already: clinical, which covers essentially the whole of the GP curriculum; stats, which will talk about evidence interpretation, research interpretation, understanding certain graphs, understanding how to do calculations based around medical type decisions; and then admin, like we mentioned, basically how things run. So primary care organization, ethics and regulatory framework, certification, legal issues. We'll talk about some of these when we do our examples. But 80%, 10%, 10%. It's really important to not leave these 2 10% blocks alone. Some people say, well, look, if I do really well on clinical, then I'll be fine. Actually, sometimes understanding a few key principles around stats and admin can give you some good, nice, straightforward marks. But if you leave it all to chance, then it's a lot of pressure to leave on clinical because there are some channel questions. Right, let's have a quick go then. So I'm going to go silent for about 50 odd seconds, have a pause, and just jot some answers down as to whether you think it's A, B, C, D, or E for the first clinical question. Let's go. Okay, guys, thank you so much. We've probably had about 150 answers, I'd guess there, and a huge range. We've had answers of A, B, C, D, and E. And this highlights some important things about AKT type questions. So well done if you got the answer. The answer is D. Renal artery stenosis may lead to hypokalemia. We'll talk about that in a second. But there were answers all across the board. So there's a couple of things from technique that are really important in AKT. Now, when you have a limited time frame to read a question, 57 seconds, we tend to skip certain things that can make a big difference. So for example, you get double words here. So which of these statements is most correct? Sometimes you have most incorrect or least correct. Those things make a difference. Double words often can confuse your brain. So it's important to make sure you're looking at the right thing. Sometimes we skip the initial word and get it wrong in the first place. So you're looking for the most correct. So you're looking for a true answer. So I would change any double words into a single one. Which of the following statements is true? It's much easier for your brain to recognize true rather than most correct. And the true answer is D, as we said. Other things are false. A lot of people put A as true. Nephritic syndrome may present as a classic triad of proteinuria, edema, and hyperalbuminemia. I wonder how many of you who put true read that as nephrotic syndrome. Just give me a yes if you read that at speed as nephrotic syndrome and put that as a true answer. Yeah, quite a few yeses coming in, and this is a great example of where speed of reading can make a big difference. So your knowledge is there, so you've learnt nephrotic syndrome, you might have even learned nephritic syndrome, but we kind of very quickly read that as nephrotic and then put that as true. And the moment you've made that true in your mind, you almost read down the rest of them and kind of make them false because you think this is the true answer. So this is where technique can play a huge difference. Lithium is unlikely to be a cause of renal impairment. The key there is unlikely. So again, if you put B as an answer, please just give me a yes if you read that as likely. Lithium is likely to be a cause of renal impairment. Just let me know if that was the case. Yeah, quite a few yeses coming in there. So that's a great example again of our brain word matches. So we think renal impairment, lithium, and your brain makes that connection as true, and therefore you think that's that you put that as the answer, but you miss the fact that it's unlikely. And these kind of negatives and changes can make a big difference from a technique point of view. Segmental glomerulonephritis, this is a knowledge thing. We'll come on to this in a second. The true answer is D, and again, I'll explain this in a second. And then D is unlikely that a diagnosis of polycystic kidney disease would lead to a CT scan of the patient's head. So the knowledge bit there is obviously the fact that if you have polycystic kidney disease, you could have a chance of having a berry aneurysm in the brain. So you think that's true, but then you miss the unlikely bit, and therefore you may not have that as the right answer. So these things all highlight in one question the fact that it's not just about knowledge, it's the application of knowledge, but also how technique can play a huge part when it comes to AKT exam as well. So a few quick learning points about that then. So we talked about glomerulonephritis. Remember, there are four main types: minimal change, diffuse, focal, and segmental. So understanding the difference there would be key. Lots of different presentations, and a lot of GP presentations, as you guys know, are very vague, and initial presentations can mean lots of different diagnoses, and therefore in the AKT you may get a question from initial presentation right through to do you know the guidelines for management. So that broad spectrum makes it again quite a difficult exam to prepare for. Nephrotic versus nephritic is a classic exam thing, and then of course the medications that are worth learning about, and it's the kind of classic things that you need to know as a GP and therefore can come up when it comes to an AKT. The answer to this question stems from here. If you look back at the answer D, renal artery stenosis may lead to hypokalemia, and that's true because of the fact that it leads to hyperaldosteronism and therefore ultimately hypokalemia. So the knowledge bit needs to be there, but the technique bit needs to be there as well. So I hope that's a good example of where people who just read lots and lots and lots and do lots and lots of questions can still lose marks very quickly when it comes to technique. Let's move to the second sample. I'll give you another 50 seconds. Please do jot down your answers as you think. This is an example of an admin question. Great, let's give another 10 seconds, guys. Please do jot something down. And please let me know if you have no idea, by the way, if this is completely new to you, or if you're just completely guessing. Yeah, lots of people saying completely guessing. Okay, fine. So this is a great example of the kind of regulations that you'll need to know when it comes to the admin section of AKT. And the admin section involves a lot of learning rules and time frames and things that can be quite difficult to remember long term. But well done to you if you got the answer A. The answer here is A. So what do we need to figure out from this question? Again, there has to be some knowledge because you need to know the guidelines in terms of DVLA and knowing when someone can be allowed to drive or not, but also making sure that you're not missing anything in the question. Which of the following situations is the patient allowed to drive? That could easily be not allowed there, and if you're not reading that with enough attention, you could miss that. Again, know the knowledge and get the question wrong. But the only one that can drive according to the guidelines is A, 10 days after a pacemaker insertion. Remember, 7 days is what the guidance says in terms of pacemaker insertion. All the others are incorrect. 4 months after a first seizure is incorrect. It needs to be 6 months. 4 days after angioplasty is too early. It needs to be at least 7 days for an angioplasty. 3 weeks after an MI is too soon. Needs to be at least 4 weeks. And 21 days after amaurosis frigidus is too early. So amaurosis frigidus is an example of a TIA, and the guidance for TIA is minimum of 4 weeks before they can drive. So the only one that's allowed to drive is A. So well done if you got that right. And again, these are the kind of things that you need to be learning from an admin point of view. So your cardiovascular conditions when it comes to driving, like we mentioned, MI is 4 weeks, a CABG would be 4 weeks, an angioplasty and a pacemaker both are 1 week. but it becomes 4 weeks if the angioplasty is unsuccessful. And if there are questions about angina, remember when driving, then the advice would be to stop driving if you get angina at rest, if it happens at driving itself or at times of emotion. In terms of neurological conditions, because a couple in this question, stroke, TIA, like we mentioned, is a month. If the question says multiple TIAs, then it goes up to 3 months. A first seizure would be 6 months, like we mentioned. That's why B is not correct. If someone's got established epilepsy, you must be seizure-free for 12 months before you can drive. And other neurological conditions, things like MS, MND, Parkinson's, there just needs to be some informing going on in terms of the DVLA. So again, this is the kind of stuff that you need to be learning from an admin point of view, very different probably to anything you've been learning for any previous exams that you've done in your career, but not just the knowledge, the technique plays a big part of it as well. Let's have a go with a stats question. And again, right from the beginning, just give me a I have no idea or complete guess if you don't know how to do all of this. So a few of you saying that I have no idea, which is fine. I wouldn't have had any idea how to do this kind of stuff before I started for AKT prep. Okay, so a lot of you guys saying complete guess. So I'm not expecting you to know all this now, but this is the kind of stuff that you will be getting in the stats section. So we do a lot of teaching based on how to do, this is basically all around your screening tables and how you can put numbers into tables correctly and how you can interpret those numbers and how you can therefore calculate things like sensitivity and specificity and PPV and NPV and all that sort of stuff is the kind of stuff that you need to know from the stats point of view, because it all relates to how you use research as a GP and how you can make decisions and how you can explain to a patient why a test might be good or not, for example. And that's all the kind of stuff that gets tested. So if you were doing this question, you need to, from the figures here, from all these numbers here, you basically need to construct this table, this screening table, and then know how to calculate it. And we put these little arrows on to show you that. So we're looking for specificity here, and the specificity arrow is this one. And the way that we teach you is because the arrow goes down, it's got to be 5 over, so specificity is this one, so it's going to be 80 over 80 plus 10, and therefore it's 80 over 90, and that's why E is the answer. So well done if you got E, and well done if you knew that, and well done if you guessed it. But this is the type of stuff that you need to be learning from a stats point of view. But again, once you learn how to do this, then it becomes easy every time. Whereas if you go into an exam like AKT and think, well, I won't bother too much with stats or admin, I'll just focus on clinical, you're going to get a lot of these wrong because it's hard to guess this type of question. One more clinical, just to give you another sample of this then. So let's pause. Excellent. Okay, so 2 things you need to obviously know here. So you need to know a little bit of medicine. You need to know about injuries and how they might present in primary care. And if you don't need need an X-ray, for example, trying to think of what a potential cause could be. So you've got to know your clinical stuff, but then also there's a technique thing in here. So a lot of you who've put various answers might have done it because you missed out the word not, for example. So just let me know with a yes if you read that really quickly and read which of the following descriptions or findings is classically matched to the injury, because that's what we tend to look for first, the positive correlation. Was there any of you who did that? Yep, quite a few yeses coming in. And again, that's classic technique. And you can see how very quickly you do that sort of technique error or miss out small words like this, 5, 6, 7 times throughout a paper, suddenly you're going to start to drop marks, not because you don't know things. So well done if you got the answer. Knee injuries are something that we see quite commonly. D is the answer here. So the one that is not classically matched is D. Positive varus test is not linked to a posterior cruciate injury. You're looking at your kind of lateral collaterals, aren't you, when you're looking at your varus and your valgal stress test. So again, you do need to know the knowledge. So you need to make sure you've gone through knee injuries, but also make sure you're not tripping up based on things that you overread or oversee because of the speed at which you're doing a question and the technique side of things. So if you get questions on knee pain, generally in teenagers, 2 classic conditions to think about: Osgood-Schlatter's disease and chondromalacia patella. Again, these often get very confused. And then you've got your Ottawa rules that you need to know for knee, for ankle, and for foot to first work out, does somebody need an X-ray following their injury? But if they don't need an X-ray, then you've got lots of things that can suggest from an examination point of view what a potential cause might be. So twisting, pivoting in the story, for example, can lead to a meniscal problem. Hyperextension leads to your cruciates damage, for example. And like we mentioned here, positive varus or valgus test can indicate your medial or lateral collateral ligament injuries as opposed to your cruciates, which is why this is an incorrect one. So again, A lot of you saying that you might have known this medicine, you might have done some reading on this even, but if you didn't get the technique bit and you missed out the word not, then again, unfortunately, you get the mark wrong. So AKT is a balance of two things. It's not just about how much do you know, it's not just about pattern recognition, it's about knowing a certain amount and then making sure you're not losing up or tripping up based on technique. And that's where teaching might become important, and that's why technique plays a huge part. So for example, word matching, we will see something in the question, I don't know, like the word iron, for example, raised iron, and you look at the answers and you'll see the word hemochromatosis. Now your brain is going to make that word match. There's nothing you can do about it. You've learnt that connection for many years. AKT is kind of saying, well, we know that you should think about hemochromatosis when you see a raised iron, but in general practice, what is the most common reason for this finding? It's not going to be hemochromatosis. It might be, it's gone up because of an acute phase reactant secondary to an infection. But because you word match, it's very hard to break that, and therefore you might get the answer wrong, even though you knew that that's probably not the most likely cause. And that's where small words are powerful. For example, usually or often or common. We often oversee these small words because we're looking so much for the bigger words, and therefore the knowledge is there, but we get the question wrong. So small words are often much more powerful in an AKT exam than other exams that you might have done in the past. We talk a lot about soft versus hard words. So anything like can or may or sometimes, they're much more likely to be true, because even if it happens 1 in a million, it's going to be a true statement. Whereas hard words like always or never are very unusual when it comes to medicine. Very little is 0% often or 100%. So when you start to pick up even subconsciously soft or hard words, it can make a difference from a technique point of view, and then making sure every word fits. So for example, making sure you're not missing the not or the most, for example. I mean, sometimes we overskip these, and we get drawn to the big words, and we make word matches, and we put answers and we get them wrong. So technique is hugely important in AKT. And often overlooked, I think, in terms of preparation. So how do you prepare? I think a dual-based approach is super important when it comes to AKT. Often what I see is people just do thousands of questions, right? They'll just get a question bank and just do question after question for 6 months. And yes, question doing is super important because you need your brain to constantly be problem solving and understanding these types of patterns. But you're going to have gaps. If you just rely on questions, you're going to have gaps in your knowledge, and therefore you're going to get to the exam and have questions you have no idea about that you're guessing. So at some stage, you're going to have to be filling up your knowledge levels as well and doing some background learning, however you choose to do that, whether it's reading guidelines or watching courses or whatever it might be. But you don't want to just be relying on questions. So we talk a lot about this dual-based approach and splitting time appropriately. And the curriculum is important to understand where your knowledge should be. Technique, like I said, is very underplayed. And if you just go and do lots of questions, you may miss out on big gaps in technique that can multiply throughout an exam. If you imagine there's a type of question that you haven't quite cracked yet, and that type of question happens 5, 6, 7, 10 times in an exam, suddenly you might be losing quite a lot of marks. You've got to pay attention to technique. Question banks, I often get asked about things like which one and which is the one to do and what's the best one. I don't think there's a best one. I think there's a best one for an individual. So one person will find one question bank, and the way that they explain things is very useful. They'll learn a lot, where somebody else might not. So you just got to find one that resonates with you. Do all the samples on all the websites and find out, okay, which one can I see myself learning from the way they explain. But what I would say is don't rely on only one. If you just stick to one and do thousands of questions from one source for 6 months, you start to almost get used to the way they write questions. So you start to almost be able to answer questions based on prior knowledge of how they write them, more than the knowledge that you have itself. So your brain kind of pattern recognizes. So when you start to do a second one or a different style, you don't quite fall into that trap, because often people do one source and they get to the exam and they realize these are very different style questions to what I've been used to for the last 3 months, and it can throw you a little bit. So a second source often is very useful. This could just be a book from the library or some other kind of free resource. And then mini targets, very important. It's such a huge amount of volume to cover, whether you're looking at the number of questions to get through, but also the amount of curriculum to cover. So make sure you have little targets. So this week I need to do this many questions, or this week I need to have covered cardiology, for example. By doing that and almost writing a plan out can allow you to de-stress in terms of how much there is, because you've got a plan in place and you know you're going to get to the end. And this is really important. Start early. Don't leave AKT prep until a month to go or 6 weeks to go, because it is very stressful when you get into it and you realize just, gosh, how much there is. Background revision, how can you learn best? You've got to Figure out your learning style before you go and get lots of resources. So do you learn through listening? Do you learn only by watching? Do you learn by doing things on screen or on book? Or do you learn face to face? So until you kind of understand the way that you learn best, you may put a lot of time, energy, resources, money into things that are supposed to help you, but you're not getting any added value. So it's important to sample things first, make sure you know how you prepare best, and then go full in, because that way you're going to make much better use of your time. And this is mentioned by Sonali earlier in the leadership talk. Develop a group at VTS. Virtual group is so easy these days, and just make yourself accountable to other people. So sometimes when you just kind of say, well, I'm going to prepare 3 months on my own, it's very hard to stay motivated for a long period of time. Whereas when you're in a group and you've told people what you're going to do and made plans, you become more accountable and you're more likely to get things done. And of course, you can bounce off ideas and talk about things that you're not quite sure about. So an AKT group is super important. When it comes to the old CSA, people used to find study groups and do lots of role playing, and that really helped. Whereas with AKT, typically people tend to do it solo. So if you can get a group going, I think that might be really useful. What can you do early on, even if you're an ST1, to start thinking about AKT? Definitely start looking at the curriculum. It's a very big document, and it'll probably scare you initially in terms of how much coverage there is. But unless you know what you're up against, you're kind of walking in blind. And therefore, if you just go to a question bank, and expect them to cover everything, you're going to have gaps in there. So make sure you have some kind of idea about what is needed and what sections I need to cover, just so you know that you've got some plan to go forward. Nice CKS, very important. Often there are lots of different guidelines. Take COPD or asthma, for example. You have your big two. You have your NICE guidance and you have your BTS guidance, or your NICE versus GOLD guidance. What do I learn? NICE CKS, remember, is the primary care amalgamated guidance for GPs. So if there is a NICE CKS guidance on something, and there are for most chronic conditions, this is a good starting point rather than trying to learn all the different individual guidelines that may be locally there for you or even nationally as well. Do make use of social media. We talked about social media already in the previous talks, but I'll talk about how we can help you passively learn throughout the day as well, because often with AKT, yes, you're going to have some time where you sit down and do work, but we try and teach you passively throughout the day as well when you're flicking on streams. I'll talk about that in a second. And read about what you see. If you're an ST1 and you're not thinking AKT just yet, just start a little bit of preparation early on. So you see something in the day, even if it's not related to the patient directly, a condition that they've got that wasn't related to the clerking that you did, just spend 2 minutes later on having a quick flick about it, because later on it'll be easier when you actually sit down and start to do your work going forward. We've really briefly gone through AKT right now, but if we have our 6-week webinar coming up on Tuesday, Pooja, if you can just put a link in the chat for that, that'll be great. It's a free, for every AKT exam, we do a 6-week check webinar and we do a 2-week check webinar just to kind of get things stimulated. We'll have at least 10 to 12 sample questions, so it'd be worth jumping on that webinar on Tuesday if you haven't registered for that already. I know a lot of you will have already. How can we help you then? So our daily emails are there for AKT and RCA. It's called Aurora Daily. Every day at around 7 p.m. we send you a quick email which has a clinical question like this. Quick question, on some guidance or some investigation or some presentation, and then a really quick video, 60 or 90-second video that covers that guideline in detail. So even if you're praying for AKT, you had a busy day, you can't be bothered to go and sit down and do some work, you just at least watch this one video, at least get your brain stimulated. And say you do that for 3 months, that's 90 different learning points that you've done without even thinking about it. So all you do is go to the website. There's a red bar at the top which says join Aurora Daily. You click on it and put your email address in, and we start sending those emails for free every day. If you don't like them, you can unsubscribe, but it's worth giving it a go. Again, Pooja, if you could put a link directly for the Aurora Daily sign up in the chat, that would be good. And then we mentioned social media. We do lots of teaching on social media. I know a lot of you guys are already on our social media streams, which is great, but if you're not, then we have 2 areas on Facebook that we use. So our main page and our GP training support group. We do lots of daily teaching on there. Instagram, if you're an image learner, then just pick up your phone right now. If you're on Instagram, have a look at us right now and just follow. If you don't like it, unfollow, but at least you learn by pictures and images and colors. Some people, these stick really quickly, much more than reading, for example. Loads of videos on YouTube, at least 400 plus videos on YouTube about guidelines and things that you might find useful. And we also teach on Twitter, and we've just started teaching on TikTok as well. So if you like funny videos and comedy and you learn that way, we've just literally started about a month ago. We're doing our AKT countdown for the next exam. So have a look at us on those streams. And in terms of resources, remember everything is 20% off today with that code CONFSAVE20. When it comes to AKT, we have our main gold package, which is basically a discounted bundle of all of this stuff, which I'll go through in a second, or there's everything individualized. So we have our main big mock live course where we do a lot of work on technique, like some things that we talked about earlier on. We focus heavily on this, so we do one before every single exam. There's one on the 4th of April, and there's one for the October exam as well. We have 3 online courses, so clinical grammar, super stats, and awesome admin. So these are courses that you can get up to 12 months, and you can pause, rewind, go back to. There's full PDF packages you can print out and make notes on, because some people learn very much by reading and watching on screen. We have our audiobook courses, so we have our clinical stats and admin audio courses. So these are designed to download to your phone basically and just listen when you're commuting or traveling or shopping or whatever it might be. They buy you time basically. So if you're in ST1, for example, and there's no expiry on these, so you can get them at ST1 and keep listening to them multiple times. We have online mock exams, so when you're getting close to the exam as well, and of course our clinical flashcards and our posters. So any of these things are 20% discount today, remember, and we'll put some links up in the chat as well. So hopefully that covers AKT. We're going to briefly talk about RCA before lunch. Just a quick poll to launch again to see how many of you guys have done RCA. Guys, just a quick yes or no if you can, just to let us know where we are in the RCA process. I guess many less will have done this than the AKT. Where people are, so the majority of you haven't done RCA, so this is obviously a new assessment, not just for you guys, but for everybody really, because it's only came about last year because of the pandemic. So let's quickly have an overview of RCA. So what is it then? A recorded consultation assessment. Temporary replacement, like we heard from Professor Martin Marshall earlier, for the CSA exam because of the limits of travel due to the pandemic. It's been approved by the GMC for CCT as a GP trainee, so you still get your MRCGP. Of course, it had to go through that process to be approved before it was allowed to be used. And essentially, it's kind of a look back at what used to happen. So you record your consultations in your general practice setting. So you have to record and submit 13 recorded consultations showing you demonstrating certain skills and managing certain situations. You record it from a central digital platform, it's called 14Fish, and they'll explain how to do that when you get close to it. You can upload them directly through their platform, or you can record them on your phone, for example, and then upload it that way. So there's quite a lot of ways to get the tech working for you. Consultations have to be recorded in your current working environment. So if you're working at home, or you're shielding, or you're doing purely telephones or videos, it's whatever you're doing in your current GP practice, you can record them. So audio, video, face-to-face, home visits, there's a big variety. And it's designed to take into account the recent changes in general practice. Of course, before the pandemic, yes, there used to be telephone consults and video consults, but now obviously they're much more integrated into mainstream general practice. So that's why this assessment has been designed for that. When you submit your 13 stations, each of them is marked by a different assessor, and you're marked on 3 different domains for each case. Data gathering, so basically trying to understand the issues of a case, both clinical issues, mind issues, psychosocial issues, ethical issues, etc. Interpersonal skills, so how's your rapport, and that can be assessed both on telephone, video, or face-to-face. Things like cues, demonstrating emotion, patient-centered care, reflection, that sort of stuff will be important there. And then, of course, management, not just from a clinical management point of view, but managing the situation. So managing the clinical, so knowing what to treat, what to test, what to investigate, when to see them, how to refer, how to follow up, but also things like managing their minds, so expectations, and managing worries, and managing psychosocial things that you might have picked up in the first half. So data gathering is about understanding the issues in front of you. Managing is about managing the situation in front of you, and often this gets reduced to a history, and this gets reduced to clinical management, and the RCA and the CSA before that is obviously much more than that. So as we said, face-to-face, video, audio, or even visits if you're doing those. I put not telephone triage here because there's a difference between a full audio consultation and a telephone triage. Telephone triage is doing an assessment and seeing whether someone needs to come in to see somebody. An audio consultation is doing a full assessment on the phone and then having a plan in place. That might include seeing them, but there's also other things that you need to be demonstrating management of, and there's a big difference between triaging and an audio consult. If your case goes beyond 10 minutes, only the first 10 minutes of that consultation will be marked, including examination time. So they'll just pause at 10 minutes and anything beyond that won't count. If you're doing a face-to-face consultation or a video consult, then ideally both faces should be visible on the video that you submit. And the level of challenge that you should be submitting is what is thought to be appropriate for challenge as an ST3. And that's a very vague statement, and we talk a lot about in our teaching what makes a challenging case and how to make a seemingly simple case more challenging and how to make a really challenging case seemingly more simple. And that's a balance that you'll pick up as you do more and more recording, and it needs to be continuous recording. So you can't, for example, do 5 minutes, pause, and then restart. It just won't be counted. It has to be 10 minutes of complete recording without any edits. So how do you select your cases? You're supposed to try and demonstrate as broad a mix of cases as possible. You can't have more than 2 presentations from any particular curriculum area, like respiratory, for example. You should try and have new presentations if possible instead of chronic disease, primarily because you can demonstrate quite a lot of skills in a new presentation, but you inevitably in general practice are going to see people who will come back again. And there are certain minimums that you need to make sure you tick off. 1 case age under 16, 1 case age over 65, 2 cases that require examination or an explanation of examination. So for example, you could submit 13 telephone consults, but in at least 2 of them, you need to be demonstrating an explanation as to what you're going to be examining and why, the rationale behind it. And then there are some essential clinical areas. So 1 case at least of maternal reproductive health, 1 case of a long-term condition, 1 case of an acute problem that needs urgent investigation or referral. So that could be someone that's admitted to hospital or urgent investigation in terms of blood test assessment, etc. And then 1 case of a mental health condition. So there are certain stipulations, but otherwise you have a pretty blank sheet. And some people find it very easy to get a broad mix, but some people find it quite hard depending on the area that you're working in and the style of patients and presentations that inevitably come to you on a day-to-day basis. So let's think of a really quick example then. So this on seemingly would seem a pretty straightforward case. 30-year-old female comes in, you do a history, it's a classic migraine, and you have a discussion in the second half about the guidelines for migraine, and you start some treatment and send her home. Now, in theory, that's a really simple case. Now, in something like an RCA, if you just do a clinical history, do an examination, diagnose a migraine, treat the migraine, send them home, you may well get a pass because you've not done anything wrong, you've not made any mistakes, you've not made any errors, but you may not get the highest scores that you're looking at. Why? Because you may have not demonstrated certain levels of skill or in that 10 minutes. And sometimes there's so much more that you can put into a 10-minute consultation than the clinical bit. Whereas because we're medics, we tend to focus on what's the diagnosis and what's the treatment. And if we do that, then we've done a good case, and you have, but it may not be enough to get you the highest score. So for example, in your clinical bit, you've probably covered this already, but make sure you need to do a focused clinical history of the headache itself. So by focused and structured, I mean things like going through things in a methodical way, showing organization in your thoughts, not throwing questions all over the place. So 2 people might ask the same questions, but one shows a lot more organization and a lot more focus. Ruling out red flags, of course, maybe you're seeing this person with a migraine for the 7th time. Maybe you're not going to ask all the red flags if you're seeing them there and then because you've done it before, but because it's an assessment, you have to go back to the beginning and make sure you're doing all of those things to make sure you're demonstrating your ability to rule out significant pathology. Going through indication of a CT head, maybe that's one of the things that this patient thinks that they might want at this point. So therefore, you need to make sure in your data gathering, you've clearly gone through the reasons that they would need a CT head, so that in the second half, you'll be able to explain clearly why they don't need a CT head. Of course, looking at medication history, going through all those basics, and doing some kind of focused clinical relevant examination. So all that might include the clinical part of your data gathering, and you may not do each of those things if someone just comes in for a headache and you diagnose a migraine, for example, particularly we've seen them before. There's all the psychosocial links. These may not necessarily change what you do right now, but they're going to impact in terms of understanding more issues that you're able to show a broader management plan for. So for example, dealing with the work, looking at stress levels, looking at habits, things that may be triggering the migraines, for example. Because again, if we don't get these issues out in the first half through data gathering, then you're going to find very little to be able to manage in the second half, apart from the guidelines for migraine in terms of clinical Understand the mind, of course, very important. That's why ICE is there, isn't it? Trying to dig out certain things that may well pop out near the end of a case or may not come out at all, and opportunities where actually you could have demonstrated your ability to manage more than just the clinical migraine. So understanding maybe that deep down this person has a fear of a tumor, and that's why she wants a CT scan. Exploring what do they know by migraine, so that when you start your explanation, you're not just doing a standard migraine explanation, you're tailoring it to what the patient has. All this is part of data gathering. So if you're just doing a clinical history and working at migraine, you're probably not giving yourself the best chance to A, manage that situation properly in real life, but also B, not to demonstrate ability to score higher in something like an RCA. On top of that, there may be the need to manage the fact that a patient is getting quite demanding about a CT scan. So again, how do you handle that within your 10 minutes? Do you do an appropriate explanation of migraine? Is it a 3 or 4 line long-winded thing that causes more confusion, or are you able to succinctly explain it in patient-friendly language? And then of course use the guidance appropriately. So understanding that there are some nice CKS guidelines on migraine in terms of what first line, second line, what's used for prophylaxis, and being able to put that as part of your management plan, not making that your management plan, but bringing that as part of your management plan alongside managing the fear of the tumor, alongside managing the demand for a CT scan. That's what makes your management plan bigger than just the clinical stuff. But being a clinician, we want to diagnose migraine and treat migraine. But in an RCA type assessment, there's much more that potentially you might be able to explain and demonstrate. So if you're thinking RCA, most of you haven't done this yet, but it's important to start thinking about it at some stage. And like we heard from Professor Marshall earlier on, there's likely to be an amalgamation of RCA stroke CSA, some kind of combined assessment that takes into account some face-to-face stuff through video probably, and some recorded stuff as well. That's probably what's going to come in 2022. So, but the principles are going to be the same in terms of data gathering and management from the sounds of it. Become curious, of course, yes, do your clinical work, and yes, rule out your admissions, and yes, rule out your red flags, but don't forget the mind. If you don't understand the patient's mind, then you can't manage their mind later on, and understand the psychosocial links. What in their life is impacting the medical problem, or how is the medical problem impacting their life? And if you don't understand those things in that data gathering part, then you're going to miss out on opportunities to help them, but also score better. Think situation, not condition. Your brain, again, is going to think this is a migraine case. How do I manage a migraine? Whereas actually, if you think I've got a situation in front of me that needs managing, that the migraine clinical management is part of that situation, but there are other bits that I need to be managing as well. Your brain will go to condition first, but if you can start thinking situation first, you're going to cover more. Don't aim to finish in 10 minutes. A lot of people get very worried about the ability to get to the end by 10 minutes. It's just the first 10 minutes are assessed. So you need to get to a point by 10 minutes where you've demonstrated your ability to manage a situation, not necessarily come to the end and put everything in a closed loop and said bye. Often that stress of time makes you more doctor-centered and more pressurized, and aim for a 1 in 10 ratio. You know, when people start recording for RCA, every case that you come to is not going to be the perfect case. So I tend to say a 1 in 10. If you need 13, you're probably going to need to record about 100 or plus videos, and therefore you record every single case that you do over a long period of time. Eventually you'll find the ones that you want. Sometimes this is a lot shorter, sometimes even longer, but don't hope that every single case that you record is going to be perfect, because you'll get very frustrated and demoralized by trying to look at that ratio. So if you are starting to prepare for RCA, we do have lots of things that help for this as well. The main flagship thing is our RCA Gold package, Gold Pass Pack, which covers everything that is in this list at a discounted bundle. We have a live RCA immersion course. The next one I think is the 11th of April. That's aimed for those people doing the May RCA or the October one, which is probably going to be announced at some point soon. This is a pretty intense day where we do live role playing and we give you direct feedback on how to manage your 10 minutes a little bit better. We have our RCA online course that it can be taken up to 12 months. I break down 90 different common presentations, how to think about approaching them from a data gathering point of view, but also the guidelines and management and coverage as well. We have our audiobook bundle for RCA as well, which is 2 audiobooks in one, our clinical flashcards, and our poster, which is mainly for CSA, but people do use it for RCA in terms of how to assess certain situations. So that's all our RCA stuff. And remember, 20% discount today until midnight with the coupon CONFSAVE20. So to summarize then, the exams in GP training are very possible, very, very possible. Yes, people do fail them, but most people pass them. But how do you pass them? You've got to plan well, you've got to plan early, and you've got to have smart preparation. It's not just about putting the hours in. Yes, someone who puts 100 hours in, someone puts 50 hours in, doesn't mean that the 100-hour person is going to pass more. It's about, what am I actually putting my time in? Do I understand what's being assessed of me? And can I target those things rather than just try and cover everything and hope that everything goes okay? You're always preparing, of course. Even if you're ST1, you're preparing for AKT and RCA, and that's why we suggest to read little bits here and there, even from ST1 onwards, because when it comes down to AKT, to leave everything to that, you're going to start to get quite stressed. And please do take advantage of passive learning. And once again, if you can get onto that free email that we send out every day, you can get onto our social media streams, you're going to start to build up knowledge even when you're not trying to. And that's kind of the aim of our social media teaching, to get things seeping in even when you're not in that stressful state of trying to learn everything. Great, so session 2 is coming to an end. If you're still there, as a lot of you still there, give us a feedback. How's this session been? Has this been useful, helpful? Has the exam stuff been useful? Did you know it all already? Let's get some feedback for this before we jump into a lunch break. Good, excellent, people are still there. A little bit stressed about exams, don't be. That's why it's good to know about these things early on. Good, really glad to see some of those kind words come through.